just to get started, Jimmy, you talked a lot about the microcatheters. When would you actually use a push microcatheter versus a torqueable microcatheter?
That's a great question. I so rarely use push microcatheters. So thinking about what's in that portfolio, Supercross, Fine Cross, now Telemark, a new entrant to that technology. I think the benefits of push microcatheters are cost and ease of use. Generally speaking, for wire exchanges. So I've got my workhorse wire down the distal vessel. I need something simple and straightforward to exchange that wire for something supportive like a wiggle. We're not using push microcatheters for CTO intervention at this point in history. I don't know if people still are in the Pro Water and Fine Cross days, but generally speaking, for wire exchanges, that being said, you'll find that the push microcatheters tend to get hung on calcium or stent struts, and you may end up buying a regular turnpike or something anyway. So usually I'll just jump straight to a regular turnpike or other torqueable microcatheter for wire exchanges and not have to deal with the headache. Elias, any thoughts on that?
No, I agree. I mean, it's essentially a wire exchange tool. I think, one of the things we worry about with using an over-the-wire balloon to exchange a wire is kinking of the shaft and not being able to get your wire down. I don't know that a hypotube, essentially, a push microcatheter, changes that. So like you, I just don't use them very much. I prefer the torqueable microcatheters.
And then you can't, leave out the ability to trap. I think that trapping techniques are very important for us to master in complex intervention. Didn't talk about it much tonight, but using trap liner or other techniques to do that. And I think that doing that with an over-the-wire balloon for wire exchanges is very difficult, especially in a six French system. So using a pushable microcatheter, torqueable microcatheter, all of the above makes it so that you can use trapping techniques and not have to work over 300 centimeter wires, which I think I've called a lot of things evil tonight, but that's one of them as well, with circumflexes and ISR and calcium. I think that's it.
Okay, you talked a lot about planning ahead of time. And, I think one of the decisions that can be difficult is when do you use guide extension? And when you do, how do you plan ahead to use a trapping guide extension versus non?
I'll start off with that one.
Yeah.
As I mentioned, I think in the talk, a guide extension has become a standard part of our, what we call assembly for our complex PCI cases. And we tend to default to a trapping guide extension. I think it just adds another tool that you can use ad hoc during your case rather than having to then call for the tool, add it to your assembly, add it to your guide. We just put all of that in up front. Again, it saves time. Efficiency is extremely important for these complex cases. You don't want to have additional steps that were unnecessary that just add time for your staff, fatigue for you, the operator. Again, our standard approach, our standard of care is just to go in with a trapping guide extension up front.
Yeah, I think, as a Boy Scout, we were taught to be prepared, and it's always better to have it and not need it than to need it and not have it, especially if you've been struggling to get a microcatheter across a lesion in that wire across gear won't go aspect, and you've got the micro down, and now you're having issues with deliverability of other equipment or getting the wire distally, and you want it at that point, where then you would have to give up your microcatheter, your balloon, your stent, whatever you've worked so hard to get down. So I guess anytime that we're pulling a guide extension, we're pulling a trapping guide extension at this point for the majority of our cases. I think that doing trapping balloon techniques with either a standard PTCA balloon or the trapper balloon with a guide extension in place does get difficult with navigating the distal aspect and getting through the collar into the guide extension. So having it built into the guide extension itself, again, through reverse cart with a trap liner, using that to pin the retrograde wire so that you can advance your microcatheter, having that all as part of a system. Whenever we're pulling a guide extension, we're pulling the trap liner at this point.
Yeah, I will say that if we end up pulling a guide extension ad hoc, meaning you're kind of in your main interventional cycles, or MIC, to go back to Lanzer's terminology, it tends to be a non-trapping one. Because at that point, you delivered a wire, and what you're after at that point is either guide support or assistance in delivering a stent or some other gear into the vessel. So that tends to be a non-trapping version at that point.
So essentially what you're talking about is maximizing your effective ID. And so is that something you plan ahead of time prior to the case of what you actually can cross through there based on the type of lesion you're engaging?
Yeah, I think that Elias did a great job of showing 7 French guides are our default for complex intervention at this point, for bifurcations, for calcium modification, for chronic total occlusion. So that's the best way for us to maximize our ID is by having a bigger guide and then using guide extensions that help with that with regards to inner diameter as well. Never want to get in a situation where you have multiple wires down, especially in CTOs where it's been a hard time getting across, only to find that your system is not compatible with your atherectomy approach, your stent choice, your bifurcation strategy. Having broken off a few stent shafts in a 6 French system before I realized I couldn't do it with certain products. Always bigger is better. So that ID extends to guide extension, but the guide itself, and then making sure that your equipment's going to be compatible with where you're starting and where you're going to complete the case successfully for the patient.
Yeah, and one other thing to think about is, when you're going 7 French, you're certainly going to have risk for more contrast use. But if you have a guide extension that you can intubate the vessel with, and we tend to use manual manifold rather than the assist in these cases, you really have more control over your contrast delivery and still get decent opacification of the vessel without having to waste a lot of contrast.
I have a couple of questions specifically about the turnpike. You talked about the 4 different types of turnpikes. Do you guys use the turnpike gold? And if you do, what type of clinical situations would you use that in?
The gold for us is a rare event, but it's occasionally used in heavily calcified disease. That's really where we find its use. We do find that antegrade, the turnpike spiral, does most of our cases without any issues. So we tend to go with a turnpike spiral first, antegrade, and then the gold, as I said, occasionally, but it's a relatively rare event.
Yeah, I think the vessel has to be, as you said, calcified or heavily fibrotic or something where the turnpike spiral is not going with good wire purchase, and a relatively straight segment of vessel, like a mid-LAD or a mid-right coronary if you're going to pull something of that size. Otherwise, you can work through that, wire across gear won't go strategy with laser atherectomy, other forms of atherectomy, nosing involudes for BAM, et cetera, to get it done as well.
All right. So when you typically set up for a CTO, what do you pull? What is that initial set of products or things that you pull for each CTO?
So I think that we may be a bit different than most. So we will have a 6 French long sheath, so the 16 centimeter slender sheath. I'm a distal left radial fan. Elias is a traditional left radial fan. His arms are much longer than mine. And so I'll put a 6 French distal left radial sheath in, a 7 French traditional right radial sheath in, again, a 16 centimeter. Sometimes, again, we have to use the 75 or 85 centimeter R2P sheaths to defeat subclavian tortuosity. We're using 7 French antegrade supportive guides, 3D right or AL1 for the right coronary, EBU almost exclusively in the left. Sometimes if we're working down vein grafts, et cetera, AL is a go-to guide in that standpoint. And then, some of our staff is here and on the call, so the gear, what give us the gear is a guide extension antegrade, a trap liner that's 1-to-1 size with the guide, so usually a 7 French, a turnpike spiral, and then a workhorse wire, something that's relatively safe, and then we quickly escalate from there. In the retrograde, we generally will start with a workhorse wire just to hold our guide in position, especially if guide engagement's tenuous. And then if we go retrograde, pulling a smaller, lower profile microcatheter that's still torqueable, and then a trap liner in the retrograde as well, if we get to that point, if we're going to put in a microcatheter.
Yeah, and that really covers, I think, about 80% of the cases. The other 20%, we may go radial femoral. So Jimmy shudders whenever I say femoral, but there are
I gave
cases,
up radial for Lent, according to everybody in the lab, so that's fine.
So we will have to pull an 8 French system femoral. We always go 45 centimeter destination sheaths from the femoral approach, whether it's 7 or 8. But Jimmy described really the bulk of our cases being now biradial with these 7 and 6, or rarely bilateral 7 access.
I think that we don't have access to 8 French radial sheaths, dedicated radial sheaths, at least in the U.S. And some of the techniques that we need, IVUS guided cap puncture, so putting a non-rotational IVUS into a side branch in order to identify a cap, And then having a microcatheter in that you can work over does require an 8 French system to get both of those in there. Some of the more low-profile IVUS catheters may not have that same limitation. And I think that if we have, like a case I showed at the end a couple of times, the failures where we had issues with guide support, if I have a patient who's failed and is coming back in for a reattempt, whether that's after SPM or just a pure failure of ability to cross, then going 8 French groin gives us a little bit more support. I don't think that there's really any utility in going bigger than 8 French at this point.
All right, we're going to change gears just a little bit. How do you go about combating the resistance to change from both physicians and staff for use of interventional tools to produce better patient outcomes?
Yeah, I think starting with the staff, what I have learned just here recently is taking the staff to national and international meetings is an incredible tool to combat that resistance. I think, at least for us, when the staff see that we're not just two crazy guys doing these cases and that there is an international collection of folks who do these and are very thoughtful about them, are very thoughtful about outcomes and patient care, then that starts to break that ice and get the staff engaged. I think among physician partners, it just takes a few early wins, especially if it's one of their patients, to start to get that friction and that grip, I should say, to start to break that ice and get buy-in. And that's really what we've seen. I would say that process probably takes about 18 months to 2 years. And I think our timeline probably has been about that, about a year to 18 months. And now we're really, I think, sailing downwind.
Yeah, I think that those opportunities for staff, and as you said, Elias, when we came to CTO Summit together with our group, they said, oh my God, they're actually doing the same things that you guys do, and you aren't making up these terms, which is great. Sometimes we do, though, but just to test them. In any case, I think that staff engagement and then working through events like this to have people out, have a chance to interact socially, makes them realize that you're not the mean guy who comes in and makes them do 4-hour cases with you, but then also understand why it is what we're doing. How is it that we're benefiting patients? We're making them feel better, and some other ancillary benefits potentially for these complex cases, and a lot of complex cases helping them live longer. And sometimes they lose the sight of the forest for the trees of each individual case. Similar for our partners is opportunities to educate. I still remember early on in our CATH conference experience getting emails from partners saying, oh, I thought CTOs weren't supposed to be fixed. It was contraindicated. Opportunities to educate abound, and partnering with companies like Teleflex and others to provide that education to people and make sure that everybody's brought up to speed on guidelines, on data, on appropriate use, and upon what's best for our patients. That's what we're here for at the end of the day, is to help people feel better and hopefully do the things that help them live longer.
So Elias, you talked about your coronary therapeutics program and about the need to have buy-in from groups, but what about outside of your department? Do you have buy-in from CT surgery, echocardiography? How are those ancillary or outside services tie into your CTO program?
Yeah, I'll start with cardiac surgery. That's a huge one. I think without a very collaborative, thoughtful group of surgeons, it does add some challenges in building a program like this. And I've just been floored by how thoughtful our surgeons are and very eager to innovate. They've, as I mentioned, I think in the talk, they've become skilled at doing mid-cab lima to LADs. And that's an extremely important tool for some of these patients. We'll find that patients go back and forth between our groups because they know that we can offer something that is better for that particular patient. And then vice versa, we oftentimes will send our surgeons patients for bypass or a mid-cab after they've been sent to us for CTO PCI because, again, we know that that is a better modality for their long-term outcome.
I think that in addition to the cardiac surgeons, we've also been blessed with really great partners from anesthesia, cardiovascular anesthesia, from pulmonology, our non-invasive partners, the imagers, the echocardiographers, the stress test people. Our CATH conference is a little slice of everybody who works in the hospital who manages these patients on a daily basis. And there's been great support for what we're trying to do at St. Thomas and then, across Ascension nationally. And we're all here for the same reason, as I said before, to help people feel better, hopefully live longer at the end of the day doing those things they can do. And the buy-in has been good. I think that, again, having dedicated people from each group to specialize and bring their expertise to the table, whether that's in the evaluation, the treatment, or the follow-up, all 5 phases of intervention has been great, and it's an incredibly collaborative atmosphere across the board for physicians and providers at our institution. So generally speaking, it's bought in.
Yeah, anesthesia is a big one. I think that's extremely important. I think doing these cases with a CRNA just makes these like night and day. I think these are long procedures. There's a lot of discomfort in laying on that table for a long time for these patients. And so, traditional 1 in 50 really doesn't cut it for these cases. I think they are just as much a factor in success in these cases as, the operators or anyone else involved.
Okay, we're going to switch a little bit over to imaging. So with regards to distal negative remodeling, how do you decide where to stop stenting based on IVUS?
So you obviously don't want to injure stent in a positively remodeled segment. The ultimate trial showed us that if you can find a segment with less than 50% residual plaque burden, proximal segment expansion, etc. But we try to find a spot in the distal vessel where we're convincingly in the true lumen. We're not going to stent in the extra plaque space, ideally, with less than 50% plaque burden. That's our spot. Of course, with intravascular ultrasound, you can use MLD max or plan, land, and expand, depending on which mnemonic you want to keep in mind. But either taking the vessel size and scaling down 1 stent size, or the lumen size and going up 1 stent size, still applies for these patients, giving nitroglycerin at the end in order to expand that vessel when you re-image. And then even, as I said earlier, the vessel will grow a 0.5 millimeter, 3/4 of a millimeter over the course of a PCI, over the course of a procedure. So making sure you do that final IVUS, which has been shown to improve outcomes for all comers, in order to size distally to the right size. Ideally, we would bring the patients back 6 to 8 weeks later to make sure that we have fully expanded the stents. Not a luxury that we have in the U.S. at the moment, so doing it right the first time. And I think that the other nuance to it is if you're in between 2 stents and you could put in either a 3.25 or a 3.5, and your stent platform at 3.5 will go all the way up, but 3.25 gets limited at maybe 3.7 or 4.0, picking that larger stent size and potentially under deploying it or deploying it just to nominal in that distal segment would be ideal. And sometimes you get results like I showed that the distal vessel just looks pruny, and it does grow over time, and these patients feel better. And if you have the opportunity to recath them, generally speaking, they do get that bigger. But I think that the use of intravascular imaging is nearly mandatory for these procedures and most PCI nowadays.
Yeah, I agree with the imaging part. And I think we also have learned to become more and more comfortable with balloon angioplasty, especially for outflow sort of distal vessel beds. And then walking away and then bringing the patient back. And, it's better to take that approach and walk away from a balloon angioplasty that may not be absolutely perfect, and then come back, a couple months later and take a peek and see what you do need to actually stent after the vessel's repressurized. That's really important for durability. It's much better than, putting a 2.0 stent in a horribly diseased outflow vessel that's not going to stay open.
So do you see a role for OCT with the modern high-res IVUS?
OCT, so back to those cases that we looked at earlier, there are points during a CTO procedure specifically where you cannot inject antegrade, or you can, but there's significant risk of dissecting the vessel and then your day's done, or you're into the STAR SPM pathway. The use of OCT requires the injection of contrast or other agents in an antegrade fashion in order to opacify the vessel. Would be interesting to see a paper if you could get imaging in a retrograde injection with OCT in the distal vessel. I've not seen that described. That would be really cool. So somebody please do that, or we will. So I think that OCT in our practice has a role with regards to stent thrombus without immediate explanation, looking for stent strut fracture, which is better than the higher definition IVUS. Light as like ultimate definition. And then also for plaque erosion. So a person comes in with a thrombotic mid-right coronary, you perform mechanical thrombectomy of that, and there's no underlying atherosclerosis. Was this embolic, or was this a plaque erosion that then exposes the patient to future events? And how are we going to treat this with anticoagulants versus antiplatelets, so on? So I think that OCT provides that benefit. I think that overall OCT, and we know from Illumian 3, I think that OCT and IVUS are equivalent. Hopefully 4 shows benefit in that population, similar to IMPROVE. But I think that having high definition IVUS or OCT is generally adequate. But at the end of the day, our workhorse still is the non-rotational solid state product for most of our cases.
Yeah, I think, as you kind of said, OCT is great for understanding the histopathology. Especially in cases that are ACS cases where it's not quite clear just from angiographic imaging. But in complex PCI, you're just trying to do a good job with PCI and trying to get optimal stent apposition and expansion. I think IVUS is really, that's going to be the workhorse for that. I'm not sure there's lot of a role for OCT in that.
Pick one and get really good at it and use it 100% of the time. And the only issue is that in CTOs you can't inject antegrade sometimes. So that's why we are IVUS heavy.
So I'm going to leave you with one final question. Knowing that becoming a CTO operator is a journey. It's something you start off learning skills as they progress. What advice would you give to a fellow starting out in the interventional space on what steps do they need to take to become a CTO operator?
I guess I'll take that one.
Yeah,
we first. It's a great question.
We had such different pathways to this.
Yeah.
So yeah, go for it.
I think first piece of advice is patience. This is a journey, as Eric, as you mentioned. I think it's a 5 to 8 year process of getting to the point where you're comfortable doing this kind of in terms of the most advanced anatomy. I think that's number one. Number two is find a partner in this. Even as a fellow, whether it's an attending mentor who's passionate about CTO and wants to do it well, this is not well done solo. Obviously, there's a lot of people out there who have done this solo and done it very well, but for the vast majority of us humans, it's hard to do. And not just for fellows, but also early career interventionalists. As you get out, if CTO and complex PCI is going to be your niche in your practice, find someone else who you can work with to do this. I think the third thing is be collaborative and be nice to your staff, to your vascular surgeons, to your cardiac surgeons. This is multidisciplinary. So I think patience, find a mentor and partner in this, and be nice.
Yeah, I think that the 3 A's apply here: be affable, available, and able. And you want to be nice. You want to be available to your referrings, to your patients, to their families, and be able to do the work. I had the privilege of training under mentors who did CTO PCI as part of my second year of fellowship. And a lot of people have learned on the job. So different approaches to it. And if it's something that you as a fellow who's starting your interventional career now want to really focus on, there are lots of great CHIP fellowships around the country where you can train under the superhumans and get the experience that you need to come out of training and start day one. Now, again, I think that it is incredibly important to find that collaborative atmosphere. If it's not in your institution, find it somewhere in town, find it through industry, through reps, through proctors. This is a team sport. I'm big on saying that everybody from the hospital janitor to the CEO can come in and say, hey, I think your distal wire is not in the right spot, or this is extra plaque. And we'll pause and look at it. So having people that you can lean on, that you can call, that you can FaceTime and say, hey, what would you think here? What do you do here? The CTO community is very collaborative and very collegial, and it's a family. And I think that people who do this for a long time develop relationships with one another. And you have the opportunity, if there's not somebody at your institution doing this at the moment, or nobody else who has that great interest or passion that you do, find somebody in town who does, whether that's physicians, reps, otherwise, and then proctors that you can help get set up through industry. So it's a team.
I'm going to ask one question at the end of this. I said that was my last one, but
You
just
did.
as an extension.
Okay.
You've talked about a lot of tools and a lot of different skills tonight that you use as a CTO operator. And knowing you don't just learn those all at one time, are these tools and skill sets that folks can use in their normal PCI as they're learning and progressing towards CTO? Or how do they incorporate these tools and skills into that progress?
I absolutely think that this is not reserved for people who are doing CTO PCI. Back to the golf analogy, you start on a par 3 and then work your way up to championship level courses, but you have the same bag, and you learn how to use your sand wedge, your pitching wedge, your 9-iron, your driver, all the same, regardless of where you're playing and how you're playing. Doing it on a lower risk patient where it's still indicated to use these tools. We don't want to purchase items that aren't completely necessary. Sorry, Amy. And do things to make the procedure unnecessarily complex. But if there is an opportunity there where you know you're going to need a supportive wire distally and you would use an OTW balloon, pull a microcatheter, use a guide extension, practice your trapping balloon techniques, because when it comes time to do CTO or the more complex cases, you're going to need that. I think that PCI, even if it's simple, low-risk PCI, can be made easier through a lot of these tools and techniques that you develop over time. Similarly, I think that complication management also is a great skill to have. Not that I want you to cause complications on purpose and then treat yourself or treat it, but using dissection reentry techniques, using balloon angioplasty, coiling, covered stenting, fat embolization, so on and so forth in complex PCI is easier if you've had a chance to do that. So seek out those lima side branches with anterior ischemia where people are convinced that's causing the issue and put some coils in that. That way you know how to use the detachable coil before you're panicking in a distal vessel perforation. So these techniques are usable in straightforward PCI and lower risk PCI and also in the complication management realm that before you need it in a higher risk situation.
Yeah, and learn one at a time. I would say, pick a month where you're going to say, okay, I want to really understand guide extensions and learn to use them well. Work your way through that, and then move on to microcatheters. I really think microcatheters have revolutionized what we do, and so get a good handle on understanding where to use a regular turnpike or a spiral or a gold, and you probably need 2 or 3 months of just kind of focusing on that and understand microcatheters, and then move on to the next thing.
Yeah, I think Bill Lombardi is famous for saying, set a timer for a year from now and then look back and say, what did I do in the last year to get better? And then pick something over the next year to work on, or 6 months, 3 months, whatever it is. Master a technique, use it when it's appropriate, become facile so that when you need it in a high stress, high intensity situation that you do it with muscle memory and rote memorization.
All right, thank you both very, very much tonight. We very much enjoyed your presentation. Again, this is Dr. Haddad and Dr. Kerrigan, and on that, thank you on behalf of Teleflex for attending, and we'll close tonight's presentation.